Thank you, Paulette and Loretta, for that outstanding presentation. It really is extraordinary to see the way that research and clinical care are working together with the single goal of improving the outcome of every individual child. And now, to see that Zero is available to every child in Australia diagnosed with cancer. I'm sure we'll only see that impact grow. So congratulations to the entire Zero team for making this happen. For those of you who don't know me, my name is Simon Truscott and I have the privilege of being the chair of the Children's Cancer Institute. And it's now my pleasure to facilitate tonight's Q&A session. So we now have on stage, they've preempted this, thank you, very slick operation, Professor Michelle Haber on the far right. Next to her, of course, is Dr. Richard Mitchell, who you've heard from earlier, Dr. Loretta Lau, who we've just heard from, as well as for the first time tonight, Associate Professor Paul Eckert, who's the Deputy Director of Research Themes at Children's Cancer Institute. So welcome to the stage, everyone. So through this Q&A process, what we'd like to do is examine this research and clinical partnership in more detail and look towards how the Minderoo Children's Comprehensive Cancer Centre will help us enhance this. In a moment, I'll throw out to all of you in the audience to ask your insightful questions, so put your thinking minds together. But first, a question from me for all the panel. I'd like to ask what excites you most about the prospect of the MQuad-C? Who'd like to jump in first?
Go. I'll start. So, as I said, we've worked together for 40 years with the clinicians at the Kids Cancer Centre. But to do that, it's been hard work. You mightn't think it is, but clinicians have day jobs being doctors and scientists have day jobs being scientists. And if we've wanted to think about creating programs like Zero or any of the other partnerships that we've had with the doctors, to do that, we have to make an appointment. We have to walk up the road or they have to walk down the road. If our scientists are doing research on clinical samples, they have to walk up the road, they have to go with a canister, it doesn't matter whether it's raining, canister in one hand, umbrella in the other, pick up the samples. Honestly, I'm trying to paint the picture for you, but it's exactly what happens. And they then walk down the road and they bring it back to our labs. They're two separate worlds. Our joint vision and commitment to partnering together to save the lives of kids and make their journeys better has meant that for this 40 years, those clinicians have made the time and our scientists have made the time. But everything we've achieved has been in spite of that tyranny of distance. What this will do, for me, this is the thing that's so exciting, is that we will have my desk next to Richard's desk. We will have a single common tea room. We have the clinicians, the scientists, everyone working together in the one space. The single tea room is critical because there will be nowhere else in that beautiful 20,000 square metre building that we've designed. Everything about the design of that has been to drive integration. So there will be no other space for unless you want to sit in a lonely corner somewhere because you're really antisocial. If you want to have lunch or a cup of coffee, you will go to this common tea room with that water cooler effect. And the way that we've designed it is that they're large floor plates so that it's only one level or at the max 2 stair levels from anywhere in that building to that central area. So you can pop down. You don't even have to get into a lift. You can meet people on the stairs. Everything is designed to drive those conversations that will drive innovation. And to me, it's just so exciting that we will be brought together in a way that will allow us to exponentially drive the speed at which we can bring innovations to these kids.
And we're not, it is a tea room, but perhaps appropriately symbolically, we're calling it the heart, because it will be the heart. And I think that is very much an exciting part. I would agree with everything Michelle has said. That's how we roll. But I would actually challenge the paradigm a bit here. Why am I excited? Because nobody's ever done anything like this before in this country. It's a little bit what I was banging on about before. We have the opportunity to rewrite the landscape. You know, we can say we want to do this. Why? Because we're the Comprehensive Cancer Centre and this needs to change. If we're really going to do this properly, if we're really going to enact proper change, because we've been banging away at this for 40 years and doing a superb job and pushing the boundaries and making sure that we're making change. But if we really want to change the landscape, we have to push ourselves. And so that is an opportunity here. We have everybody aligned internally and externally to do something really amazing, something that has not been seen before. And I think that's the really exciting thing for me.
It is exciting. And Loretta?
Yeah, I'm going to be the practical person here. So today I actually made 3 trips from the hospital to the research institute, and I think it cost me about 45 minutes backwards and forwards to make these 3 trips, and including stopping at the traffic light and jaywalking as well. So if we are all in the same building, then I would have probably saved 45 minutes today.
Yeah. And what about you, Paul?
Yeah, I'd like to talk maybe about a motivation that hasn't been mentioned yet, but I think is really important, and from the scientist's perspective. We're all there to do our best, really, for children with cancer, but there's also a sense of excitement and potentially a thrill in the discovery when we get the opportunity to unpick that Gordian knot of an individual's cancer or find something. And the ability not only to share that with colleagues in that environment, to perhaps infect them with a little bit of our enthusiasm and excitement that comes from the bench, but also to know that that has a pathway forward. It just doesn't stop at the door into the lab. It finds its way out into the world in a manner that's very different to the way it happens now. It's published in a scientific paper, it takes years, but now we can share these discoveries with our clinical colleagues and with our friends and the people in that Comprehensive Cancer Centre the day it happens. And I'm just so excited to see what impact that makes. Like Richard, this is something different, it's something new, and I really want to do the experiment. Yeah.
Housekeeping, there are microphones on both sides of the aisle. Over to you, audience. I'm sure you've got lots of questions you'd like to ask. If you do have a question, just raise your hand. I'll do the same just to block the light so I can see. And just perhaps quickly introduce yourself.
Hi, can you hear me?
The questions. We can.
I'm interested, given the capacity, is the capacity so great that how do you determine bed allocation?
Could you just repeat that?
How do you determine who has access to the facility? How do you work out who can get in? Or is the capacity so great that every child with cancer in Australia can gain access to this remarkable...
Oh, yeah. So that's not a thing. So first off, anybody that requires treatment, no matter where they come from, already gets treatment. So I'll keep this short, but let me take the premise of the question. So what is my catchment? What is our catchment, right? Like, who do we look after? At this point, at the moment, of the people that walk through the door, of the children and families that walk through the door, 60% of them come from outside of Sydney. That's just our cohort. Moving forward, there's going to be more of those children outside of this state. There are only 9 paediatric centres in this country that treat children with cancer. We all know each other. So whoever needs it, I guess, is the short answer. There is no limitation from that point of view. Yes, there's capacity, but that's not our consideration, and it would never be a limitation. And because of the benefits of our health system, to be honest, we just make it work. So everyone is the answer to that question.
That's good news. Others? Yes.
Hi, I'm Jo, and I was just interested to hear your vision. I loved the description of the heart. I'm wondering, from the young child's perspective, what your vision is, and for the family as well. We've got this beautiful vision of the clinician, the researcher. I'm thinking of a child that would walk past and we'd go, oh, that's where the researchers might be. I'm just curious to hear your vision of that.
So For a huge amount, and I'll let Richard talk about the details, but a huge amount of the design, which extraordinarily we were reflecting with the architects just last week, that we built this on Zoom basically through COVID. The funding was announced in 2019, March 2019, and the tender for the architect and the building was all towards the end of that year. So this whole planning took place through COVID. And one of the key things was about the journey of the child and what that would be like. What we've done with this building in terms of the design, for example, as you walk into this new building, a hospital, one of the first things you'll see on the ground floor is a public discovery laboratory. So what we're wanting to do is to bring to the families and the parents the vision of that hope. So it's not just a word, but they will actually be able to see scientists working at the lab bench as they walk in. Richard will tell you more about the design of the labs, but this is, so the other thing I want to say is one of the shining beacons of cancer research and clinical care in Australia is the Victorian Comprehensive Cancer Centre, which is where we got our inspiration from to do this. That's in the adult space, the first comprehensive cancer centre for adults. It was piggybacked off the back of that, literally in the grounds of the VCCC with the then Health Minister, Greg Hunt, where we said, imagine if we could do this for the kids as well. And in speaking to the people at the VCCC who similarly have their labs and their clinics in the same building, they told me the one mistake that they made, which was that although they're in the one building, they have two lifts. And when you come in, you're either a doctor or a patient that goes that way, or a researcher and a scientist that goes that way. So although it's in the one building, the design has actually not driven that alignment. So in our building, it'll be that in the lifts as you go in, there will be children on drips, there will be scientists, there will be people with stethoscopes around their necks. So that whole vision of integration and alignment and one team working together will be there front and centre for every patient and every family that comes in, as well for our scientists to be inspired by what they're doing and to inspire the clinical staff and the hospital staff about what the researchers are doing. So the whole physical building is that same. From wherever you sit, you can see that integration and that alignment and all working together. I'll pass on to Richard.
Yeah, I mean, that's an excellent summary. An example is level 5 of the building. You get into these lifts. I mean, hopefully those people with stethoscopes don't get in the road. I don't know who they are, but anyway. You go into level 5 of the building, you walk out of the lifts, you go right, you're getting outpatient treatment as a child, you go left, you go into our wet lab. Right, so it's literally all as a together. The other point I think you're making, and I think that's the other focus that we really had, is about the family journey and about the patient the patient heart. Because one of the challenges that we have is that families are stuck in hospital for a long time, and getting access to an extended family. We took a lot of consumer input into our patient or our clinical space design, a lot of input. And other than telling us they all wanted their own single room, which we heard loud and clear, we have very extensive, I guess what I call extended family spaces. We have a beautiful family designed kitchen, which is literally designed so that on the weekend when the extended family come in, they can all sit down and have Sunday dinner together. You know, different kind of spaces, because to be honest, for a while, this becomes their home. And we need to accommodate for that. And that comes back to making that journey better. And so there's a lot of considerations around all of that, as well as what Michelle has outlined in terms of the public laboratories, the communal space, the way we are coming in and out of the building. So I think as best we can, for many respects, I think there is going to be really true integration, which carries different things. We've had discussions internally, for example, very confronting for the CCI staff to be in that clinical space, but we're ready to tackle those things. And I think it will help, take people to the next level in terms of, what they want to do.
Michelle and Richard, are you guys ready to share an office?
To be honest, Paul, I was thinking we're never there at the same time.
My question, a little more seriously, is, and I think you've been talking about this, but I think I know it's top of mind. How do you think about, like, your shared passion, and the passion of the four of you for integrated and comprehensive care is very evident. How do you make sure that everyone buys into that? And if this is a new way of treatment, how do you ensure that they adopt this as fully as they can? And there's clearly physical things you're doing in the hospital to make it happen, but what else are you doing to make that happen?
Sorry? Speak to the zero thing first. Sure. So I don't want to do all the talking, but I'd like Loretta to actually speak to our experience with that, with even the zero thing, right? Because that's already a thing. Do you want to speak to that for a second?
So can you repeat the question? I didn't quite get it, sorry.
Could you just repeat the question in terms of how effectively how are you slowly going to make a difference in working?
Would you like me to speak without an accent?
Yeah,
how are the scientists and the researchers and the clinicians on the other side, how are they going to adopt this new way of working together?
Okay, got you. So I can give you a very good example. So we had a very successful Zero Symposium last week, and we have international people coming from Toronto, Canada, and the Netherlands, from very big pediatric oncology center. And they got invited to join us in our curation meeting, and they got invited to join us in the molecular tumor board, and they were most impressed because we actually have everyone together in not really a physical room, but a virtual room where, so me as a clinician, I have a colleague of mine who's actually based in Melbourne, and we do very similar things for Zero. And I also have my, what we call clinical fellows, who I'm actually currently training in precision medicine, to be in that same group again. And then I have Paulette's team, who are essentially the curation scientists looking at the molecular data. And then I also had, the bioinformatician who actually helps us deal with the massive data, all in the same room, talking about a real patient. And that's the most important thing, because we all learn from each other. And so what are the international people most impressed about is that we can all work together in that same room to discuss a patient. I said, oh, don't you do the same thing? They said, well, not really, because what happened to them is that their scientists work together and look at the genomics data, and then they issue a report to the clinician to look at, and then talk about the report to the family. So they don't really have this connection that we have. So in my mind is that being in the same building, be it like a physical and a virtual room, I think makes a huge difference to what we do for children with cancer.
Richard or Paul, do you want to add to that?
I would just like to add to that, and it's building perhaps on what you said, something that you said earlier, Richard, in your spiel, which was that without Zero there would not be an MQuad-C. And one of the reasons for that is Zero's been the training ground for this, and the model for this different type of interaction. Before Zero, there was no such thing as a molecular tumour board. There was no forum where every week all the oncologists, paediatric oncologists in Australia got together. That did not exist, literally. It exists now. That doesn't mean everybody's put away their personal, clashes or their jealousies, but what it means is everyone's learnt this and grown together. So I think the model exists for this to work. No doubt we'll have to test some of these things as we go forward. We're going to learn more, but I think we've had this experience and it's been formative in my view. I think there's scientists here who know infinitely more about the disease that they are researching than they ever did 12 months ago, and there's certainly clinicians who know infinitely more about the genes that are driving the disease that they treat. And so I think that model is going to be incredibly important. It really makes this work.
And I agree with all of that, but not to dodge the question, because all of that's a little bit rainbows and fairy dust, and that's great. But I think the word I've used more than any other time tonight is the word change, right? And I mean, scientists love to continue to do things a different way. Clinicians love change. So, you know, it's a significant challenge. And when we speak about what our challenge is moving forward, it's taking a culture and combining it and moving it forward. And so that's our responsibility. You know, we have to, you know, infuse the passion into everybody that works with us to realise this is what we're trying to do and why, and that it is a good thing, and it will take time and resources, and we'll get some of the things wrong, but we'll get a lot of things right, as evidenced by what my colleagues here are talking about. And so you've just got to kind of ride that and move forward. And I think that, you know, I still, you know, some might be put off by that, but I think it's really exciting. I think, you know, personally, my opportunity to be able to take people on this journey, because it will be a journey, but I think it's going to be a really good thing, and I think we'd be able to forward on the other side.
Michelle, you wanted to quickly add something.
The only thing I would say is probably one of the most exciting 2 days of the year, and the one that all of our research and clinical leaders look forward to, is a 2-day off-site where we do have our clinical leaders and our research leaders in the room together with our external, highly distinguished national scientific advisory panel, where we share our joint vision for individual projects, for Blue Sky. We talk through what we have achieved and what we could achieve together. And it's a hothouse, a vibrant 2 days of creating the future. Now, that we've been doing that for several years now, and the clinicians sort of vie for who can get off duty for that day, because we're usually in, you know, down the south coast or somewhere like that, so we get everyone out of their normal area. But taking that and demonstrating a much broader part of our cohorts, both at the clinical site and also the research area, and exposing them to that sort of environment, that program of change is what we need to be setting in place over the next 12 months now, so that everyone can see what it is that we're signing up for and become part of that.
I just wanted to throw a quick question to Richard. You've talked about change and the journey of the patient. What about the journey of the family? We've got a number of families here tonight who have been affected by childhood cancer in their family. How will the MQuad-C change things for families?
Well, there's ways that I hope it will change things. I mean, I must be hesitant to speak about this journey because it is, you know, I always, when I give speeches, talk about the privilege of working with our patients and our families. And I always describe them as superheroes because we witness feats of enormous strength in the face of the utmost adversity. That's true of multiple people in the room. I can see them from sitting here. So I'm hesitant to speak to that, but we hope that we make the journey easier. We know that it's the hardest thing in the world to have a child diagnosed with cancer. And as best as I can understand from observing it for so long, it's not just, well, it doesn't matter what the outcome is, the journey is barbaric. I'm quoting words from a previous family whose daughter is alive and well. So we have to make it better.
Yep.
And so how do we do that? Well, we do our best. We provide better facilities because ours are not up to scratch. You know, we have single rooms. We have those kinds of, from an inpatient point of view, we have a home. We have somewhere where patients feel that they're safe, where patients feel that they can get through the journey. And from an outpatient point of view, because as all these families will tell you, we have somewhere that's more efficient. And so if we can provide that, as well as providing new therapies, different therapies that make the journey better, if we can find ways to make the journey better and less hard, then hopefully we can help the next generation of the families coming through in a better way.
Liquid biopsy and just the...
Yeah, I guess.
I think there was a question from the floor.
Simon, there was just one comment.
Michelle wants me to just talk about one other thing briefly. An aspirational translational project which we are moving very quickly on. You know, those who support CCI will hear a lot about liquid biopsy. And I think in the CCI sense, we talk a lot about identifying relapse and new therapies. That's 100% true. But another vision that we've talked about a lot that I've got for liquid biopsy is about improving the journey. So very briefly, but liquid biopsy is about identifying single cancer cells in a body. Take the example of a child with a solid tumour. They get diagnosed with that solid tumour. Part of that diagnosis is I talked about the MRI before, took a scan, right? A scan that is necessary. For most small children, that requires an anaesthetic. Even if that treatment goes well and the tumour melts away, you have to do a scan at the end to make sure that it's gone. And then as we move forward, we have to scan that child regularly to make sure there's no new tumour there. Now, if we can get liquid biopsy right, instead of putting that child through an anaesthetic and a scan every 3 months, we can take a sample of blood and take it to the lab and say, don't worry, you're still cancer-free. Now that changes the journey, not only for patients here, but imagine that you're in Wagga. Imagine instead of the 4.5-hour drive, the overnight stay, the 4.5-hour anaesthetic, the next overnight stay because you're too tired to drive back, the 3-day trip, and then the 3-day wait to say, yeah, no, the scan's okay, don't worry, see you in 3 months. Or go to your paediatrician at Wagga Base Hospital, send me a blood sample, we'll tell you in 2 days. That's
incredible.
How we change the journey.
We have a question from the floor.
Simon, you mentioned the reference to the family in relation to the possible and potential circumstances that may happen and the impact that it might have on the family. And Richard, you said that 50% of the patients, approximately 50% of the patients, will be children that will come from the country, and they will be staying in areas like the Ronald McDonald House, where I was associated with for many years. Is there any thought being given to promote this magnificent new centre and its concept to the management of the Ronald McDonald houses across Australia, to give them some understanding of what country families can expect when they arrive? Because some families can stay up to 5, 7, 9 months in a house from the country, first time ever in the city, and I'm just wondering whether you would consider some appropriate approach to the management of the Ronald McDonald Houses Australia to give them some idea of what this magnificent centre is going to be all about.
Yeah, it's the problem we haven't solved. Everything you articulate there is an absolute serious, significant issue today. I have a transplant program that can't get the next kid in because the last kid can't leave. We've identified this problem on this campus for many years, and we continue to work with everybody, including Ronald McDonald House. Yes, absolutely. Trust me, the local one is very much aware, as is the one on the other side of town, and it is something to continue to work towards. But this is a very wicked, complex problem, right? And to be honest, I don't think it's just Ronald McDonald House that's going to be able to solve it. We need to have multiple solutions to this problem. And again, there's some people in the room that I've already been talking to about this, because it's actually multifaceted, you know, depending on the children that are coming, depending on the family that comes, depending on the facilities that you need. And I don't know if anyone's noticed, but we're a bit cramped for space. You know, we lived in the most, this campus is one of the most densely populated places in the country. You know, as commented on by the minister when he came the other week, he was actually like, where's everybody in a park? But it's much more important than that. It is about how do we keep them close? How do we keep them housed? How do we keep them safe? And so I think that is one way, or that is one avenue that we definitely need to explore more about, and we have started those conversations. But there's many others that we're having too, because I've already recognised that we need a multi-pronged approach. Now, if anybody wants to go and buy a large patch of land not far from here and build a very large hotel, please come see me after. But I think the reality of the situation is we're going to need multiple solutions to this problem, and it is a problem. But there's another way out of this. Well, not another way out of it, but there's another part of this journey. It's get them home faster. right? Because that's what we still don't do well. The way we are doing that and what we are doing now, and I'm sorry I'm fidgeting, but everyone knows when I talk I have trouble sitting down. We are working with, I have, again, funded by philanthropy, I have rural and regional nurses that are working and building up our capacity at the rural and regional sites. We have a whole vision as a clinical partner of the Quad C to have a base hospital in each LHD in New South Wales. So for example, again, I've used Wagga, so Wagga Base Hospital. So everybody that is in the catchment of Wagga Base Hospital, and what can we do at Wagga? As much as we can. So you come for your really specialised therapy, you come for your translational research, and then once you post, when you need your care afterwards, you can be at home. And I'll send a clinician out there, because we already do that, and you'll have a nurse trained to look after you, and we'll have supports in place with that general paediatrician, because we'll give them the education to help look after you. So rather than stay 9 months here, yeah, you got to be here for 3 months and we need to work through that, but the rest of the time, get home. Get home with the rest of the family. Let that family go to work. Let those kids go to school. Get back into your community where your support is. This comes back to challenging the paradigm. We can't have an ivory tower where everybody comes here. That ain't going to work, and it's not the right model for families. We have to get them back to their support in their communities. So we have to have a multi-pronged approach.
I'm very sorry, folks, but we're going to have to draw this to a close. We could be here all night, I'm sure. I've got a list of questions I wanted to ask. I'm sure all of you have been thinking of them yourselves. So I'll have to call it over at this point and thank our panellists for speaking to us and taking us on the journey of the difference that the MQuad-C is going to make, and how clinicians and our researchers are going to work for a better outcome for patients. So thank you, Michelle. Thank you, Richard. Thank you, Loretta. Thank you, Paul. Incredible insights, and it is definitely an exciting time for the Institute, Kids Cancer Centre, and the future for kids with cancer in this country.